Hey, everybody, can you hear me okay and see the screen? Yep, okay.
Yes.
I'm Lauren Swagger. I'm a child and adolescent and an adult psychiatrist. I uh, I am born and raised in West Virginia. I left every state that has been mentioned. I have loved vacationing in, but your question was about where you want to live, and I am very, very happy living in West Virginia, which might surprise folks, but home is where people are, and my people are here,
I
professionally
love
and
it.
family. So I'm a happy girl, but I'll be the first person to want to jump in on all these vacation plans. Um, but today I'm going to talk to you about paranoia. This is I think was a requested topic, so hopefully the person that requested it, I do this justice for. And I wanted to approach this a little bit today, and this actually is going to be kind of similar, I think, to the lecture I give in December, because there is a lot of overlap between those topics. So I'm going to really focus on assessment today, and then probably reassess assessment and diagnosing, but focus kind of more on the treatment part. So the treatment part will be a little briefer today, but I really wanted to talk about paranoia and assessment of paranoia, and honestly, really defining paranoia. And I think when you approach the idea of assessing paranoia, you have to kind of define what you're looking for. And we have a lot. One of the things I love about this echo is we have people from lots of different walks of life, and different clinical backgrounds on here, and so this term may mean different things to you as well. But it really is a term I think that's used very differently in our patients and our population, and what they may mean by it is really important. And so we're gonna go into the weeds, uh, in the nerdy weeds with really what this is, and really how to assess it. So we're going to talk about what paranoia as a general symptom means, and we're going to talk about that spectrum of symptoms, and really at the end of the day, that the symptom complex can be seen across an array of different diagnoses. And we're going to really talk about what that symptom may look like from different etiology sort of perceptions. And then when we really can define the etiology, we can really kind of start talking about the treatment part. So these are the actual Merriam-Webster and dictionary.com definitions of what paranoia is. And the first one is kind of more of the layman terminology. So unjustified suspicion and mistrust of other people and their actions, and a tendency on the part of an individual or group toward excessive or irrational suspiciousness and distrustfulness of others. And I would say that this is probably the definition when the vast majority of patients, especially in an outpatient setting, use the word feeling paranoid, are probably describing this. The second definition is really more of the medical or psychiatric definition of paranoia as a truly psychotic symptom. And that is that it's an unwarranted or delusional, and delusional means false, fixed belief that one is being persecuted, that someone is after you. You're being harassed or betrayed by others, and it's really part of a mental health diagnosis and condition. And mental illness is characterized by delusions of persecution or grandeur, usually without hallucination. So paranoia is a psychotic symptom. And in the context of psychiatric assessments and just general clinical assessments, the question really becomes, I think, is this true? And when we talk about paranoia, we would call that a paranoid delusion from the truly psychotic sense. But as you're assessing a person in front of you with a complaint or concern, the real question becomes, where does this symptom fall on the spectrum of what this can mean? And ultimately, I think the big treatment breakdown is going to come back to, is this truly a psychotic phenomenon that I'm witnessing? Is this person truly experience a paranoid level of psychosis? And I will say, although it's there's always an exception, that the folks that come and they verbalize feeling paranoid are rarely the ones that have the psychotic level paranoia. Oftentimes, people that truly are paranoid are going to be, and of a very severe psychotic nature, there are going to be many other things that they're worried about, or you may be seeing the paranoia displayed to you in their thought process and behaviors, they're less likely to recognize or use that terminology because for them it's real. When someone is feeling paranoid, they may already be questioning it, that symptom, and that's a key part that we're going to talk about today. So how common is persecutory thinking, persecutory delusions, or this idea of paranoia? Well, from a psychotic standpoint, it's incredibly common, and about 50% of people experiencing psychotic symptomatology may experience paranoia. And so in 50% of psychotic cases, you're probably going to see paranoia. So that's almost half of all people with a thought disorder component to their diagnosis. But when we think about psychotic symptoms as a continuum, we have to understand that, psychotic symptomatology, even auditory and visual hallucinations or disorganized thinking, which are other psychotic symptoms, can all be kind of part of a spectrum of normal behavior that becomes problematic. So I thought this was a fascinating sort of questionnaire about sort of if we take, and this is a student population, but if we took just kind of a general survey of people's degree of suspicious or paranoid beliefs, what would we kind of see? And I thought this was kind of an interesting study. So look at the top, a feeling of needing to be on my guard against others, feeling that negative comments might be circulating about me, people trying to deliberately irritate me. You can see that the frequency of, especially with the top one, is almost half, right? Like 50% of the population are reporting some degree of kind of suspiciousness or feeling an on guard type feeling that could be part of paranoia. But if you go down to kind of more severe, that there's a conspiracy against me, that I can detect coded messages about myself in the press, or I'm being controlled by other people, you see much, much more rare reports of this. And so these are some of the categories of symptoms that people may find falling on that spectrum of paranoia, from that distrust to that truly psychotic paranoia. So if you're doing an assessment of paranoia, what possibly could this person's diagnosis be? And this is really where I will tell you that paranoia symptomatology, not necessarily the psychotic piece, but the symptomatology that you may be seeing along that degree of normal, may fall under a very, very wide variety of diagnoses. So let's start with sort of our anxiety disorders and trauma. This is talking about worry, whether it's social worry of how people are being perceived, or someone that truly has been violated or harmed by someone else. There's a tendency to be mistrustful or suspicious and have that need to protect yourself. And in severe cases, that can almost look psychotic, that the people are so afraid for their safety that they may appear paranoid. And we're going to talk about how to tease that out, but I would say that paranoid distrust, that more suspicious type symptomology, is pretty common in these. You'll see very high rates of that feeling. We certainly see paranoia and various personality disorders. I'm going to talk more about that. Obsessive compulsive disorder is kind of an anxiety disorder characterized by sort of having obsessive thinking or overthinking things, and then having behaviors to help sort of relieve the distress of those intensive thoughts. And some of those thoughts can become so intense that they do look irrational or almost psychotic and bizarre to people outside of the person watching them. So that can be something that can be hard to tease out. Then we have our true thought disorders, paranoid schizophrenia, where it's truly a thought disorder with paranoia being predominant. You can have delusional disorders where you just have the paranoid delusions without the other psychotic symptoms. You can actually, in a severe extreme states of both depression and mania, and bipolar disorder can become psychotic or paranoid on the far ends of severity with those disorders as well. We have the presence of psychotic symptoms in medical conditions. If you've ever witnessed someone become delirious, in a hospital bed or get disoriented. They could respond to things they see from a medical condition. Maybe their sugar's off. Maybe their electrolytes are out of whack. They can become quite paranoid and concerned as they experience things. Epilepsy can also lead to some production of paranoia from kind of the way that the brain may be wired and firing um, from a perception standpoint. Neurocognitive disorders like dementia can have components of paranoia in later stages of Alzheimer's diseases or vascular dementia, as people again are struggling to kind of perceive their environment and may feel fearful or paranoid as a result. Similar, but a little bit different with autism and developmental disorders like intellectual disabilities. It may not be that you achieve full cognition and lost skill from something like dementia, but you may not have gained the cognitive capacity to interpret your environment appropriately. So you may misrepresent things, and you may have psychotic like pathology reported like that's developmental, almost like an imagination or self-talk that might look like a psychotic symptom to someone else. And then certainly we have a fair share of psychotic symptomatology that is induced by substances. And this is a little bit of a double-edged sword. Probably the stimulants or those those substances that have very strong dopaminergic properties. So cocaine, methamphetamine, and cannabinoids have very high rates of causing psychosis in their use. And then actually those that have substance-induced psychosis may be at very, very high risk of going on to having psychosis again. That's not psychotic, is not induced by the substance. So this can be quite problematic. So when you see someone with paranoid features, you kind of got to really dig in because this could be a lot of different things, and you can't just accept, oh, I feel paranoid on you have to kind of really truly assess the entire context of this symptom. And those of you who've heard me talk before, I always talk about ABCs of assessing behavior. I'm going back to my functional behavioral roots, but you have to do that with all symptoms too. So when someone is talking about feelings of paranoia, I really need to understand it. Is this person able to talk about what is triggering that feeling? Are they able to talk about what the paranoia is about? Are they telling me the details of their belief? Are they paranoid about safety? Are they just appearing paranoid in their expressions and behaviors? Do they talk about feeling anxious? Do they talk about bizarre beliefs? Do they say they are someone out to get them? What are they saying about it? And what are they saying causes it? Or is it always there? Does it wax and wane? Is there some reality to this, or does it start getting bizarre? Have they always believed that with intensity? It could be that, well, I used to think it was just, you know, this, but it's gotten really, really intense over this amount of time. When you hear someone talk about behaviors, you have to think about what they're doing alongside the feeling of paranoia. What are their behaviors telling you? Are they not leaving house? Are they wearing headphones to protect themselves? What is happening with their activities of daily living and their functional abilities because of this belief that they're having? Is it impacting their ability to care for themselves, to wash themselves, to feed themselves? They're so afraid. And then you kind of go into the consequences. What has become of this belief? If you're paranoid that you're going to eat and someone's poisoning you, did you stop eating? And the consequences, you're really malnourished now and have significant medical comorbidities because you've not been eating food because you believe it to be paranoid. So what's happening? And a real key thing is there a separation from the feeling of paranoia, the feeling of mistrust, the feeling of fear, and their ability to step back and think about it in their brain cognitively? Can you separate your emotional discussion about it from your feeling about it from your rational thought about it? And that can be a really important thing to assess and figuring out if this truly is psychosis or something else. So how do you assess it? Well, and again, I think depending on the setting that you see somebody, this can be quite different. My first experience with like true psychotic paranoia was in a hospital, in an acute psych hospital where the person's floridly paranoid in front of me. They couldn't even have a conversation, but they were so afraid to even sit down. They were pacing and looked like they were responding to things. Um, I couldn't get a sense at that moment in time what the time frame is. But if I have them sitting in my outpatient office and they talk about paranoia in the past, they may be able to tell you, I've always been this way. I've been this way since I was a little kid. I'm only this way when I'm in large groups of people. No, it just seems to get better or worse. Can they remember when it started? Can they tell you their triggers? Do they have a sense of that? Is this something that every time they've gotten this way, they've ended up on in a hospital, or did something happen? Do they have a sense of what makes it better or worse? If they've taken medication, did it help or not help or make it worse? Did the symptoms come back if they stop the medicine? That can all kind of be part of that time frame. I also tend to ask people, when do you think you felt that your paranoia, your whatever word they're using, your mistrust, your distrust, your paranoia, your fear, when was it the worst? When did you feel the safest? And try to get a sense of the severity as well. And then a lot of the teasing out of a diagnosis is understanding the context of what's going on. Were they sleeping, or having problems with too much energy at the time they had the symptoms? Were they sad, depressed when they had that feeling? Had they experienced trauma in their past? Had they been somebody that has trouble trusting other people? Do they feel safe? What are the things, safety, especially in anxiety disorders and trauma, is really a big piece of that. What do they do to feel safe? Um, that can also be kind of telling. Um, have they been assessed before? I've seen folks that, I think in earlier parts of severity, it was hard to really tell if something became psychotic until it is obvious. It can sound more like suspicious or trauma in that spectrum. And they'll say, those things never helped, or those things made it worse, or, the only thing that ever helped me was this. Can really tell you some details about sort of response. And then, you want to understand the social context of this. When I'm around other people to talk about it, do I feel better? Or is being around other people make it worse? Those can all be, or is it just certain people that make it better? And this is, so you want to understand the system and the whole environment to really get back again to what the driver of it is. And so these are also some so this is about the belief itself. When you're talking about the paranoia itself, you want to kind of assess the quality of the paranoia. Is this how believable is this? Is this a completely unfounded, bizarre sort of belief that has no basis in reality? Or is there like a nugget of truth that just got exaggerated? Or is it just, so strange, it's completely impossible that it could be true? And that's sort of that fine line between, you can have bizarre and non-bizarre delusions. You can have things start out as perhaps truthful or even rooted in truth, but kind of blow up over time and be misperceived. So you want to kind of believe that, and you want to know how much do they believe it to be true. This is, is this a firmly held belief, or does this kind of just happen in this situation? And you can ask people, how strongly do you believe that the FBI is tracking you right now? Are there times when that was less? What was happening, right? You want to know how strong they hear it. How willing are they to consider that there are alternatives? Are they 100% sure this is the reason for their behavior? Are they willing to think, well, maybe this is the alternative? Their ability to think about alternative rationale for the symptoms. How much time does this take up? This is a question we ask sometimes about functionality, but you're awake for 16 hours a day. How much of your day do you spend worrying about, the FBI tracking you? Oh, just 10 minutes a day when I get home and check my apartment. Oh no, all day long. From the moment I wake up, I'm checking constantly, right? That's a massive difference in time. So you want to understand how long it's present. Do they consider it distressing? And this is one of the things sometimes that, we talk about that idea of ego dystonic and ego syntonic. Ego dystonic is it really bothers me. Egosyntonic, maybe I like it, but it really bothers other people, right? So how distressing is it for me versus those around me, with regards to this symptom? How much does it interfere with my other life activities? Like, is it affecting my employment? Is it affecting my relationships? Or, are those things all fine and this is just kind of contained um, in my free time? And then the idea of, um, and this is actually a really kind of important in treatment when you're talking about things crossing the line into true psychosis. And this is important if you're doing family work, or you're working with kids that might have true psychosis and their parents. Oftentimes, the true psychosis piece has incorporated their loved ones into something, and it can be completely unfounded. So if my social context is my family and I become floridly psychotic, my beliefs about who's going to be the one harming me is probably a relative who loves me and isn't really harming me, but my support is also who I fear. And that's a really important thing to recognize in treatment with psychosis is helping the family understand this is an illness and not take that personally. And it is hard. And I have seen folks, I think before things were recognized as true paranoia, kind of blaming their families for things or having disruptive family experiences or accusing their family members of things they didn't do that caused a lot of family distress before this was recognized as a symptom of their psychosis. And sometimes that's just hard because you don't automatically see it crossing that line from suspicion to true psychosis. And so, it's always, I think it's always important when, you get, I'm rooted in child. I'm always going to bring up the family in discussions, but if you're caring for someone and you really have talked about having a psychotic illness, making sure the caregiver truly understands what that means in the spectrum is also a big part of this too, because it will ultimately um, be an important part of that discussion. And then you can ask, especially if you're seeing people in that outpatient setting, when they are able to talk more about it, they're not a defendant, kind of in the middle, you can ask questions. What? Tell me, tell me how you know the FBI is bugging your house. What evidence have you come across that supports that? You know, are there things that you question about that? You know, what does how do you distinguish this worry, this thing with the as different from a regular worry? Is it just like your other worries, or is there something different about it? When you think about how you're feeling about the FBI tracking to you, do you ever wonder if this makes sense about why they would do this, or does that perplex you? And people can tell you quite elaborate stories about that. Are they confused by it? As you kind of, and sometimes you'll see this when you're treating psychosis too, you'll see it get better with treatment. They'll start questioning it. Yeah, I don't feel so strongly about that today. I think it's still a little puzzling why I felt that way, but I don't feel about it as much today as I did yesterday. And they start recognizing some change in that intensity. How did they reason about it? Some people will say, I feel really paranoid, but I know this is completely irrational. I know there's no way the FBI is bugging me. I know there's no reason for it. I just feel it. And they can talk about that being not a rational belief. That can be kind of helpful. And then what is it about it that keeps the thought or the fear going? Those can all kind of be those diagnostic things. So we get to this idea ultimately in the spectrum of these symptoms about this idea of what is reality testing. And you'll hear psychiatrists kind of use this term, but it really is this kind of fundamental idea, sort of devised by Freud about, how 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 much are you able to separate out the reality, the facts about a situation from your own feelings and your hopes and fears about them? That ability to look at that and separate those two things is really at the focus of this. Those internal thoughts and how much they're crossing into the external world is really what that line was about true psychosis. So, as you're asking people about their symptoms and their situation, how objective can the patient be? Are they able to consider alternatives? Are they able to pause and think about a different way to handle the situation or a different reason for why the experience occurred? Can they separate that emotional feeling of fear, suspiciousness from the factual cognitive beliefs? Or can they start even identifying themes and patterns of things before their reactions occur? And then do they ask people for their opinion? Someone who's truly worried or may ask, do you think I'm being a little unreasonable about this? Or they're seeking that sort of validation. If you're truly paranoid and psychotic, you're probably not, you're too scared to even ask, right? The people around you what their thoughts may be. So you can kind of, again, sort of think about how they use their environment to make them feel better or to reassess their thinking. But ultimately, this is that hierarchy that we talk about, from the more, at the top is those really severe, truly psychotic things. This is often bizarre, conspiracy theories, significant risks of harm. If you are truly in a truly psychotic paranoid state, this is what you're going to see in a psych hospital. This is, an acute paranoia with complete detachment from reality is quite unsafe. It is one of the risk factors in every safety assessment. But more times than not, you don't see that. Right? That is the extreme example. Most of the time and in most of the places, we're gonna see those lower levels and we're gonna be trying to tease it out. So we wanna know, how what is the thought, how strongly it's held, and then how much can social evaluation sort of change it. And then we want to talk about safety and how fearful the person is. And when we talk about sort of treatment needs as regards to like outpatient or inpatient or hospital levels, we're thinking about that functional impairment. How unsafe is this person? Do they have any ability to um, find safety, or do they need those four wall locked facility? Because maybe they're so paranoid they're afraid to take treatment, or they don't even recognize it as an illness to choose treatment rationally. The other sort of clues, and again, remember, we talk about psychotic symptoms. Paranoia and paranoid delusions are not the only psychotic symptom. So, to really think about it as a thought disorder, you want to look if there are other symptoms of psychosis. So, other symptoms of psychosis are other delusions, so other beliefs, false fixed beliefs of things that aren't true. They may not be paranoid in nature, but other just sort of beliefs that are unchanging and unlikely to be true. Is there a history of auditory or visual hallucinations or some other type of um, experience that's not based in reality? And are there actually true signs of a thought disorder? So those are like your inappropriate affect, like your face and your emotional reactions don't match. Sometimes we talk about negative symptoms, which is that they lose speech or they lose thinking capacity. Their thoughts may slow down. Their speech may become disorganized or jumbled. You may see those things as well. And usually, again, when it has truly crossed that line into psychosis, that question about a clear lack of reality testing is quite obvious. All right. So other things to kind of think about. So actually paranoia and OCD, although maybe on the surface really you don't think about that, OCD is often frequently missed as a diagnosis because people see the bizarre behavior, the belief. So think about like a fear of getting sick or needing to wash your hands or paranoia about germs, right? Paranoia about germs is so intense. You're seeing people wash their hands, maybe avoid things. The behavior can look really, really bizarre. It can look and feel irrational. But again, it's usually not any other clear delusions or hallucinations. There's no other clear psychotic symptoms, and people are going to describe the fear as being an overvalued fear. The rationale is not one from safety or paranoia that they're going to always get hurt, although that is sometimes incorporated into some of the obsessions. But it's going to be more of an overvalued circumscribed symptom, and you're often seeing the compulsion to relieve the anxiety of the thought. And so if you can dig in enough to get someone to talk about those things, they will separate out a little bit. And then typically there are other obsessive symptoms present, and obsessional worries that probably are not of a paranoid nature, but that paranoid component is often present in some of the fears. Paranoia is quite common in personality disorders. In fact, there's a paranoid personality disorder, which characterizes sort of a lifelong suspiciousness or mistrust of others. In fact, schizotypal, paranoid, and borderline personality disorder all to some degree have some component of paranoia or suspiciousness kind of noted. These are often quite persistent over time. They often date back to early childhood, and they may not wax and wane a whole lot. They may be characterized by very long periods of time, avoidance of people or individuals. Often you don't have the other um, beliefs or psychotic symptoms present. And you see a lot of interpersonal deficits, and a lot of the problems are functionally coming from the isolation that's often self-induced, um, to avoid the paranoid feeling. It's less likely to see it, but you can also see it more mildly in avoidant, antisocial, and narcissistic personalities too. We talked a little bit about this developmentally, but autism and intellectual disabilities. Actually, when in the 1700s, when Bueller first described dementia praecox, which became schizophrenia, he actually described it as the 4 A's. And guess what? One of the A's was autism. And so I'll always tell folks, especially in kids, if you see somebody that develops autism or signs of autism late in life, make sure that that wasn't the prodrome of a thought disorder. Because the autism, the sort of lack of social engagement, sort of the withdrawal that you see socially, those social behaviors may mimic the negative symptoms um, of, of autism and be mistaken. But there actually is, and we've talked about this in other situations too, but actually there is a little higher risk of having psychosis and autism and intellectual disabilities by virtue of the fact that, oftentimes there's already some neuronal or neurological component to that that may also predispose genetically or otherwise to having a risk of psychosis too. And so this is not to say if you have autism and intellectual disability, you cannot have psychosis, but you need to understand how they present differently. And so if you do see psychosis in autism and intellectual disability, you're going to see that paranoia, again, quite different from their baseline. But you will see constant concerns about paranoid symptoms in intellectual disabilities because these are brains that have not fully developed or even kind of a developmental stage that may still have challenges with how they're perceiving their environment, right? We talk about sensory, how you perceive your senses, how you read faces. In fact, there have been lots of studies with, some of the social deficits in autism are about they can't look at eyes and read the person's expression from the get-go. So if I can't tell that you're smiling at me and not looking scary, and they've shown that when they've seen faces where I might say, oh, this is a happy person that I could go ask for help, a person that doesn't perceive a face that way because of how they're processing the sensory information may actually be likely to misread that face as threat or fear. And this has been some of the etiology of aggression that occurs from self-protection in folks with intellectual disabilities, that not realizing that that person was trying to be helpful. They're not interpreting their environment correctly. And that can be very different from feeling paranoid. So you have to kind of think about where they are developmentally and how they're perceiving those things, as well as also assessing what their cognitive understanding of risk and fear is, right? If I have a incredibly low IQ that I'm thinking like a young child, I might not have the ability to understand all the perhaps scenarios or really truly evaluate that threat and just feel scared and unable to control my emotions to be able to interpret it. And then I don't think I need to tell anyone on this call, but having been a victim of trauma or abuse or neglect, maybe even threatened if you said anything, that belief or feeling paranoid or suspicious or distrustful is incredibly real. And that ability to find safety and express safety is really key. And I will tell you that in people that have been in an acute sort of unsafe state from severe domestic violence or severe trauma, I have mistaken it, and it has looked exactly like paranoia and psychosis at times, especially in young kids. I've not been able to tell. They've been so emotionally aroused and so disorganized. And there actually are some developmental pathways that continued trauma may look like psychosis and some early conceptual frameworks of this, because when you are so living in your fear brain, you can't do this rational thinking, and you do misperceive things, and you become disorganized to self-protect yourself. And so in the acuity of this, it may look exactly like someone is psychotic. The difference being is once they've had an opportunity to feel safe, it may look different. And so that's why we talk about looking at different points in time. It can really sort of decide that for you. And then this is what I'm probably going to get into a little bit more in the future, but um, the medication and treatment part is really tricky. If you are 100% sure you have a paranoid delusion and you have crossed that threshold of reality testing and clearly demonstrated the paranoid symptom as psychosis, you do need an antipsychotic. That is absolutely clear. Even folks that might have bipolar disorder and have psychotic symptoms in their manic episode or psychotic episodes and their depressed episode, they will not get better with an antidepressant or a mood stabilizer at all. You have psychosis as part of your symptoms, even if it's substance induced. If you have severe psychosis that's not remitting, it's not going to get better with anything but an antipsychotic. However, if it's really not psychotic, if it's one of those other things and it just looks psychotic, and it's more on those other parts of the spectrum, and you haven't gotten that line of truly being psychosis, the antipsychotic probably will not help, and you will just get a ton of side effects. And so going back to the etiologies, this is coming from a framework of depression, or this is coming from a framework of trauma. You have to go back to that understanding of that symptom to choose the medicine correctly. But if it's psychosis, it will not get better. Even if they're psychotic and have PTSD, right? Their PTSD is not going to get better from an antipsychotic, but they might not get better if they truly are psychotic, right? You have to, that's the line. And then if it's not psychotic, I cannot overstate to you how important psychotherapy is, especially with regards to OCD, the anxiety disorders, interpersonal disorders, autism, because if it's not psychotic, and all of this is coming from anxiety, or this is coming from those social misperceptions, it's going to be all the other treatments other than meds that help people get better. Because you have to develop the rational thinking, the developmental perspective to feel safe and to think through. And we also know that those are some of the hardest symptoms, like PTSD, OCD, are some of the hardest disorders to treat with medicine alone. They almost always require the need for psychotherapy to establish safety and control and regain those skills. So I don't want to not spend a lot of time on treatment, but it just cannot be overstated how critical getting the diagnosis is, or at least a framework of this diagnosis first before you kind of proceed. And then here are the atypical antipsychotics. Here are the typical antipsychotics. All the antipsychotics treat psychosis to some degree with the right dose, so they could all be considered. Some of them, as you will see, have other utilities too. Some have some indications in autism, tics, mood disorders, but all antipsychotics truly treat psychosis. Now, antipsychotics may do other things, and this is some of the other things antipsychotics do, but they will all treat true psychosis. But they are not without tons of side effects, and this is why I urge you to be mindful, because I at this stage of my life, I probably see kids with really severe complex PTSD more than anything. And I see a lot of them being treated with antipsychotics and they're not getting better, but they're getting all these horrible, terrible side effects. And other than the sedation of the antipsychotic, they're not really getting the core problem better, because these things don't treat PTSD. But they will sedate you. They cause really significant weight gain. You can have risks of movement disorders and stiffness. It's actually something called neuromolective syndrome, which is incredibly rare, but can be autonomic instability. It's a medical emergency that can happen. Lots of GI side effects. They make you tired. They slow your thinking. They all need lab work, weight checks, movement checks that have to be done. So it's not easy to put anyone in a psychotic and weigh that risk, unless you're really sure they're psychotic. But again, there's lots of other non-medication things that may be part of someone's treatment plan that that address the symptoms of paranoia, the non-psychotic symptoms, so that need for suspiciousness or safety improving. And these are all sort of interventions that may have a role in being helpful to someone is really the critical piece of a lot of the non-psychotic symptoms. All right, that is my presentation. Any thoughts, comments, questions? I'm not sure we've ever talked about paranoia assessments in all my involvement with Echo, so this one's new to me.
No questions?